So I think that one of the things that is becoming more important with all of these drugs that are approved for castration-resistant prostate cancer is the proper sequence. At this time, we really don't have a marker to help us determine whether a patient should go on further hormonal therapy or whether they should go on chemotherapy or they should go on chemotherapy up front. So for example, if a patient progresses after sipuleucel-T, we often have a decision as to whether they should go on enzalutamide or abiraterone. And there are different characteristics of these drugs which I think are appropriate for selection. So if a patient may have a lot of fatigue, which is one of the complications of enzalutamide, you may want to consider abiraterone. Additionally, if they have a seizure history, one should consider abiraterone over enzalutamide as a second-line agent. So conversely, reasons to select enzalutamide over abiraterone if a patient has severe fluid retention, that's a patient who we would go with enzalutamide first because of the fact that abiraterone can engender fluid retention. So there are different subtleties to these drugs which may or may not lend to their selection. They both have very similar survivals. They both improve survival both in the pre and post-chemotherapy states, so they both are extremely active drugs. The question is, if a patient fails abiraterone or if they fail enzalutamide, then should you go with the converse drug? And the answer is we really don't know. It does seem that if you fail enzalutamide and then go on to abiraterone or vice versa, that the second drug is less effective overall in a population of patients. Why is that? Well, we have a marker that may help us understand this particular problem. That's something called ARV7, which is expressed probably in about 20% of patients with castration-resistant prostate cancer. The interesting thing about ARV7 is what's called a splice variant. It's not actually a genetic mutation, it's in the processing of the RNA and the splicing of the RNA. And so what happens is the ligand binding domain of the androgen receptor is deleted. And thus androgen can't bind to it and it's constitutively activated. So if somebody is going to be treated with enzalutamide, they develop the splice variant, it doesn't necessarily make sense to put them on abiraterone because they won't respond. And the same thing with abiraterone, if they develop that splice variant, they shouldn't go on to enzalutamide. We should think about other options such as chemotherapy or isotope therapy or investigational treatments in that situation. So this is one of the ways in the future that I think we potentially can sequence. Now, the real issue about ARV7 is not only the fact that there's a mutated androgen receptor, but if you look carefully at the paper that was published in the New England Journal of Medicine this year, those patients who have the ARV7 also have high levels of the androgen receptor. So perhaps this is also the fact that you're overexpressing that receptor, and that's overcoming the inhibition of enzalutamide or abiraterone. But I think that this is a very important area for research in the future.